Okay, so this is more or less what we're going to go over today. We're going to start out with just talking about kind of the history of the current opioid epidemic. Then we're going to talk about what opioids are, and then how naloxone actually works in the body. And then we're going to go over just actually how you administer naloxone. And then we have like a few legislation and laws, local and national. And then we're going to talk over some like different harm reduction strategies and how it's applicable to peer support as well. And then we have some resources at the very end. Okay, so this is a graph that's showing you just the deaths due to overdose from 1999 to 2020. And there's 3 distinct periods that I want you to kind of notice. And so the first one is starting in the 1990s. And this is when prescription opioids, a lot more people were experiencing death due to overdose using prescription opioids. And so this is kind of that time period where like the pill mills were starting, and it was just a lot more common and easy to get a prescription for opioids. And so then that kind of led us to about 2010 to about 2013 time period. So this is when really that doctors were starting to lose their license because they were overprescribing opioids. And so this is when, so then basically what happened is that doctors were no longer prescribing it, and so people no longer had access to their legal and medical prescriptions for opioids. So then they ended up moving to street drugs, which was usually heroin. So this is where you start to see this orange line that represents heroin really start to increase in 2010. So that's really why we see that increase there, is because people were no longer able to get that prescription from their doctor. And then last is this purple line, which is representing our synthetic opioids. And we'll talk about what it means for synthetic in a little bit. But the most famous one is fentanyl, right? We hear about that a lot. It's in the news a lot because it is one of the strongest opioids out there, and it takes just a very little small amount. So it's also contaminated into other drugs other than just opioids, such as methamphetamine, such as cocaine. And so basically, you'll start to see an increase in like 2013, but then you also see that in 2020 it really skyrockets. And this is really, you start to see a lot more deaths due to overdose just because it is so strong. Sometimes people don't know that it's in their different drugs they're taking. And so that's kind of the history and how we got to where we are now. And so this 2020 kind of going into where we are now in 2023 really hasn't changed much. It's still definitely a lot of synthetic opioids. So this is pretty much where we're at now. Oh, thanks. Okay, so this graph is just showing the deaths due to opioids nationally as the US and then also in Utah. So you'll notice that Utah is the orange and that the US is the blue. So historically, Utah has had very high rates of death due to overdose. And like higher rates than the US as an average. And this is also why, for example, USU has this grant that we do, and why we have funding to be able to provide Narcan, because Utah has historically had really high rates. So the good news is that this is a continuation of that graph that we just saw. So you'll notice that Utah has actually started to dip down, and we have dropped below the national average. So the good news is that we are doing a lot of really great work in our communities, and we need to keep that up because it is showing. We are decreasing our death rates due to overdose. And I think previously at one point, Utah was 4th in the nation for overdose deaths, and now we're ranked, or at least in 2021, we were ranked 42. So that's the impressive part, at least, is that we are doing good work. So I do want to like have a positive note to like keep up the great things that we're doing in all of our communities. Okay, so what are opioids? Opioids are a medication that are typically used to treat pain. And oftentimes they're used to treat sometimes chronic pain from surgery, just really any sort of pain. And they are depressants, and when I say that they're a depressant, I mean that they're slowing down the central nervous system. And so that means that it's slowing down our breathing. And ultimately, that is what an overdose is that you take too many opioids, you have too many opioids in your system, and essentially it slows your breathing down or it stops altogether, and that's essentially what an overdose is. And so then this last one, this is where I was saying I was going to talk a little bit about like the difference between synthetic and plant-derived. So the word opioid comes from the word opium, because Opioids are traditionally derived from the opium poppy plant. So that means that they're plant derived. But they're also, you can make them synthetically. So you can make them in the lab, so not using a plant, but still having like the same chemistry. And so that's what fentanyl is. So there are 2 different types. They work in the body the same way, but they're going to be different strengths, essentially. So some are going to be stronger than others. Oh yeah, if you have any questions, you can also feel free to interrupt me. We'll also have time at the end for questions. Yes?
Just like with the CBD and the grass, like in the community, there is an idea that things that are natural will be less harm, and you just say that it will be different. Is that a factor also for opioids?
So they're going to function in the body the same way, and I'll show you an image in a few slides of how it works in the brain. So the difference between like a plant-derived and synthetic is that typically synthetic is stronger. So that means that you don't have to take as much to have an effect. So that's going to be the difference, is that usually synthetic is the strongest it's going to be versus like a plant-derived isn't going to be as strong. But it's still going to work in the body the same exact way. Does that make sense?
Yeah.
Okay. Okay, so, oh, there's supposed to be an image that's going to pop up. Maybe it'll pop up in a second. So this is how, just like how talking about how opioids actually work in the body. So when you do ingest an opioid, it is going to, 1, help with pain, because it is going to block some of those pain receptors. But with that, it's also going to affect like your emotional memory, your pleasure and reward system. It's also going to give you that euphoric, kind of warm, drowsy high that you typically hear about with opioids. And then again, like I said earlier, they are depressants, so they are going to slow down your breathing. See, this image does pop up. Oh, no, well, there's an image that just kind of talked about different things in your body. Because opioids, not only do they do these, but they also affect different parts of your body, such as like, it will cause constipation, it will cause like different kind of issues within just organs of your body. There was a little image that's supposed to be right here, but that's okay, it didn't pop up. But this is our main thing that we're discussing. So there are some risk factors that are going to make it more likely that someone will experience an overdose. And so the first one is just taking other medications, and specifically other depressants. So that means that you're going to be taking, if you're taking 2 medications that are slowing down your breathing, you're more likely to have an overdose. And so some of those examples are here, so like antidepressants like Prozac, or benzodiazepine like Xanax, but also alcohol, because alcohol is also a depressant. So when you're mixing opioids with alcohol, you're at a higher risk to experience an overdose. Next is reduced tolerance. So this just means that if you take an opioid after taking a break from it, you're more likely to experience an overdose. And this is really common in people who are leaving incarceration or potentially leaving treatment, or places like that where they've had like a sustained time of not using an opioid. And especially if they end up going back to their previously used dose, that means their body's no longer used to that dose, and they will most likely experience an overdose when they return to that use after taking the break. And then next is being elderly. So as we get older, our body just can't break down medications and drugs very well. Our organs just don't work as well. And that's just us getting older, that's just life. But that also then puts us at an increased risk of experiencing an overdose. So that also is an important thing to keep in mind with, older relatives, with grandparents, people who have surgery, who are prescribed an opioid, who maybe haven't previously taken opioids, and so they might not understand that how this is going to work in their body. So that is a really important thing to also educate family members, educate your peers that you work with, things like that. And prior overdose just means that they likely just have a history of use, so then they are likely to experience an overdose. And then the last one, unsupervised drug consumption. This is a harm reduction aspect of, we always suggest to use with other people, just because it's unlikely that if you take too much of an opioid and you experience an overdose, it's unlikely that you're going to be able to administer naloxone to yourself. I have heard stories of people who have administered themselves, and they knew as soon as they took like a dose or did they shot up or whatever, they realized that they knew it was going to be too strong and they administered naloxone to themselves. I have heard those stories, but it is unlikely if you are then going to be unconscious. So it's always best practice to use with other people. So here's our image of our brain. So in our brain, we have opioid receptors. And these are little blue, I don't know, T's, we'll call them that. So we have these in our brain. And this is exactly how an opioid works in your body, is that when you take that opioid, it's going to bind to those opioid receptors in our brain, and that's how it's going to, block the pain, how it's going to cause that euphoric feelings, all those things we just talked about. And so as we said too, it depends on how strong the opioid is, it depends on what type of opioid, and it also depends on the person, because everyone's body's different. Everyone's body's gonna be able to kind of intake or break down a medication and a drug differently. Okay, so here's our same image, but with our naloxone. So when you administer naloxone to someone, all it does is it actually binds to those receptors, and it has a stronger ability to bind to those opioid receptors in our brain. So it'll actually kick the opioid out of that receptor, and that's how it works. And that's all it is doing. So naloxone is very safe. There's no side effects to it. There's no way to overdose on naloxone. The only thing it is doing in the body is binding to that receptor and preventing from opioids to bind to that receptor. So the only thing with naloxone, that it only is going to work for about 30 to 90 minutes. So there is always a potential that someone might re-overdose, especially just depending on the type of opioid and how many opioids they have in their system, especially if it's fentanyl, for example. So there always is a chance that that person might experience a re-overdose after that 30 to 90 minutes, which is also why every single kit is always going to give you 2 doses. Any questions so far? So here's our different forms of naloxone. So there's 2 ways to administer it. One is intramuscular, which means that it's going to go into a muscle, not into a vein, into a muscle. And then the other one is going to be nasal, and that's specifically what Narcan is, and that's what we'll talk about today, and this is what you will also walk away with today. So we also have, so our 2 main forms of this IM injection one is, and I have it here as well, and actually at the end I do have some practice skin if you want to practice drawing up like a syringe if you're not comfortable with that. I do have some practice supplies up here. But this is definitely going to probably be the most common one you're going to see in the community just because it is the cheapest method, is getting the vial and the syringe. But there is also a really fancy one out there that you're probably never going to see because I actually think it did go out of business, but also just because it's really expensive and fancy. It's basically an EpiPen, and this one actually has a trainer, so you can also play with this one later. And
This trainer
so it'll talk to you. So you can play with this at the end too, but basically what you're doing with this fancy auto injector, just like an EpiPen, all you're gonna do is hold it up to someone's thigh, it is gonna do all the work for you. So this one, you're unlikely to see in the community, but if you do, you're welcome to come up and play with the trainer. And then our other 2 forms is this, it is a syringe with an atomizer, which just essentially means that when you press that syringe, it's going to create a spray that goes into your nose. So it's just it's just a more, lesser form than the Narcan, basically. The Narcan is just a fancier form. So Narcan is a brand name, so that's why it's called Narcan, and that's why it's only the nasal spray. It is just naloxone. Naloxone is the generic name for the medication. But this is Narcan, and we'll show you how to use this in a few slides. So yeah, so these are different forms. So that's it. It's going through the nose, it's going to go into a muscle. And then when you do say a muscle, the best place is going to be thighs. You could also give it into the deltoid muscle that's in the upper arm, just like you get a flu shot. A flu shot is also an IM shot. But I would avoid fatty areas such as the stomach. I would avoid injecting into the butt. The needles are fairly thick, so you definitely can, it will go through clothing, but they're wearing a really big winter coat. I would take off the winter coat, but otherwise it will go through jeans, it will go through most clothing. So you won't have any issue with that when you use the syringe. Okay, so how do you know if someone actually is experiencing an overdose? So these are images for our signs, and And so first we have just that breathing is slowed or stopped. And so when we say slow, we mean less than 12 breaths per minute. They might also have like a snoring or gurgling sound. It's another name for it is a death rattle. And then with the pinpoint pupils, that means they're just going to be really teeny tiny. So they're not going to be big or dilated, they're going to be really small. And the next is just the unresponsive to stimuli, because this person is essentially unconscious. They're not going to, wake up to a sternal rub. They're going to be limp. And then the last one here is this lips that turn blue. It could also be fingernails, like a healthy fingernail, you press it, it's going to turn white and then back to pink. So it might not react. Their lips might be blue, and this just means that they're not getting enough oxygen, right? Because you're not breathing, you're not getting enough oxygen. So this is why different parts of your body are going to turn blue. Okay, so you notice all these things in someone. Okay, so now what do you do? So first, you're going to do that sternum rub, where you're going to take your knuckles and you're going to rub it in the middle of their chest, and you want to press down because you want to cause a little bit of pain. Because if that person is sleeping or whatever they're doing and they wake up, then you know that they're not unconscious. But if they're not responding to any stimuli, then you know that there's something wrong. And then so next, if that's happening, you want to call 911. So you always want to call EMS or some sort of medical provider, because it is a very serious thing when someone has an overdose, and especially if they have a chronic history of use. When you give naloxone, you're going to put that person into immediate withdrawal. And so we do want to seek medical help, also because then they're going to have the skills, they're going to have the resources, they're going to have more naloxone if needed. So always call 911. So next, you've done the sternal rub, you've called 911, help is on the way. So now you're going to prepare your naloxone. And you're going to give it, and then I do have a slide in the next slide that actually shows more of the steps. So we'll wait till that slide. So you're going to prepare your naloxone. You're going to give it, whether it's the Narcan or syringe, and you're going to monitor that person for about 3 to 5 minutes. And you might need to give rescue breaths. And when I say rescue breaths, that means that if they're going to be on their back, you're going to want to tilt their head back a little bit. And then if you have a barrier, which hopefully you do, you're going to give basically one breath every 5 to 6 seconds. So that's what a rescue breath is. You're going to monitor their breathing, and if there's no response after 2 to 5 minutes, you're going to give them the second dose. Because Narcan will work within a couple of minutes. So if there's no change, give that second dose. Once again, just monitor, continue to watch for breathing. Yes?
Excuse me, but didn't they fall back? Like I have some friends that are EMTs, and they said they've fallen back from giving rescue breaths just because of the fact that opioids, especially with fentanyl, could be on the person's mouth, and you don't want to ingest that.
Yeah, I mean, if you don't have a barrier, then I probably wouldn't give mouth-to-mouth breaths. But if you do happen to have like a CPR kit that you would have that barrier, then I think you'd be safe. But also, like EMTs, they work a lot more, so I would also trust your friends. I'm not an EMT, so. But yeah, so if you don't have a barrier, it's solely up to you and what you're comfortable with. Like I personally, I don't know actually if I would give. I would probably want a barrier. I don't know if I would give mouth-to-mouth without a barrier. But up to you. So yes, but I think if you have a barrier, then you're safe because you're not going to be able to, that's the point of barriers, that there's going to be no mucus to mucus membrane. And so this is the recovery position. So if you do have to leave the person, it's best to put them in the recovery position. And so you'll see this image here. So the recovery position is that you're going to put them on their side, you're going to give a little bit of head support, and then you're also going to lift up that knee. And so that prevents them from rolling over when you lift up that knee. And so the reason we want to do this is because some symptoms of withdrawal would be like chills, sweats, muscle aches, but also vomiting is one of that. So we also want to put that person on their side in case that person does vomit, because we don't want them to be on their back so they potentially inhale their own vomit. So if you do have to leave the person, put them in this recovery position, and then I would also suggest to leave your like Narcan or Naloxone container next to the body so that if someone comes upon them, they know that at least it was given. They're happy. Okay, so here's how we actually use it, which I don't have internet, but there is a video link, but that's okay. It's pretty self-explanatory. So here's our Narcan. So as we can see, it's pretty simple. You're gonna peel back this layer, which, I mean, I can do it if you want, but, and then so we can all see that there's this red plunger, and then there's this white, I don't know, nozzle, I guess is the best way to call it. So the white nozzle is what is going to go into the nostril, and the red plunger is what you're going to press to actually expel the medication. So when you're ready, you did your sternal rub, calm 911, you're about to administer it, you're gonna peel it back, you're gonna place this nostril or this nozzle into the nostril, and you're gonna press that red plunger. And don't press the red plunger until it's in place because it will use the medication. So you don't wanna press that until it's in that person's nostril. If there is visible gunk, try to remove it to the best you can. If you need to give a second dose, you can administer it in the same nozzle, but you could also go in or nostril, or you could also administer it in the other nostril. It's really up to you. I don't think there's any best practice. Yes?
I don't know the name of the medication, but people with asthma just go like, with asthma, people.
Like an inhaler?
Whatever, but here it says,
Yeah.
what is,
Flonase?
head tilt back, so
Mhm.
it has to go to make sure that it goes to.
Yes, yeah, so you can, it does say here. So yeah, you do want to tilt the head back a little bit because it does help. Basically, when you tilt that head back, it just ends up causing the throat to open up a bit more. But mostly it's going to be, your body's going to absorb it in your nostrils because you do have mucous membranes in your nostrils. And that's actually how your body will absorb it. So if you forget to tilt the head back, you will still like give the medication to them. But yes, best practice is to always tilt the head back. Same with rescue breathing. Same concept, because when you tilt the head back, you open up the airway just slightly more.
Thank you.
But yeah, so like I said, if there's no effect in about 3 minutes, give that second dose.
What's the window to administrate that?
3 to 5 minutes. Oh, you mean as in like when you found the person?
Yeah.
I mean, as soon as you can, yeah.
Is there like a time frame that it's?
Well, if they don't have a heartbeat, technically the person's dead, but you can always administer it because you also don't know when that heart stopped, so there's always a potential. Because the central nervous system it does affect the heart rate. There's other systems that also affect the heart rate, so it could be that when this person's taken an opioid, it's depressed and slowed down both their heart rate and their breathing, so there is potential that that person can come out of that. But if there is no heart rate, technically that person is dead, but you don't know when that happened, so like I would still give it. As soon as you can, when you find the person, really, I guess that's the best answer for you.
Thank you.
Okay, so here's just some local legislation and laws. So in 2014, the Naloxone Act was passed, and essentially what this act is saying is that professionals can give naloxone to anyone who's at risk of experiencing an overdose, anyone that's at risk of witnessing an overdose, and then there's no physician-patient relationship required. So that means that you can go to any doctor. You don't have to have a previous relationship with that prescriber. I do believe that I think it is required that the prescriber informs you of naloxone or something. I don't know, some other law too. But essentially, this is the most important part. What was that?
The Good Samaritan Act.
Oh yes, we're about to talk about that in 2 seconds. There we go. Okay, so the next one was in 2016. So this is the Opiate Overdose Response Act. And so essentially what this act passed was that anyone who is an overdose outreach provider can give naloxone to anyone for future use, for current use, and there's going to be no criminal liability. So, an overdose outreach provider. Is everyone on this list? Which every single one of the people in this room is on this list. So whether you are law enforcement, a fire department person, an EMS, or if you work at an agency that's treating people with either a substance use disorder or a mental health condition. But last that we have in red, individuals, which each of you are. So that means that you can give out naloxone to anyone for future use legally. There's going to be no criminal liability with that.
And that's called Good Samaritan Act?
Oh, the Good Samaritan Act, I think, is the next slide. Yes.
So somebody in chat, they asked if you could send hard copies of the survey.
Yes. We'll figure it out. If you can get an email, that will be best. I can send it via email. Okay. Okay, so this is really new. March 29, 2023. The FDA, the Food and Drug Administration, they basically approved Narcan, and specifically Narcan, the nasal spray, to be sold over the counter, which is very exciting because at least that's a step in the right direction. That means that anyone can walk into a pharmacy and buy naloxone. You don't have to have an opioid prescription. You don't have to pay insurance, all that kind of stuff. The only bummer is that you will have to pay for it. And I've heard that they're expecting it to be around $50. Yeah.
We were informed that where I work that you can tell anybody who has Medicaid that they can go to a pharmacy and that Medicaid will cover that cost.
Perfect, thank you. Yeah. So I guess if you have, he said that if you have Medicaid, or if you're on Medicaid, that you can go to a pharmacy and they have to provide it to you and it'll be charged to Medicaid.
So, if it is not prescription, and
It's
they can ask
Yes.
that as Medicaid, they will get,
Medicaid
to
covers
keep it
the
at home.
cost.
Wow.
Yes. And so I don't think this law has quite been in effect yet. I think they're expecting it to be this summer to be mostly that you can walk up to a pharmacy and just buy it over the counter. I don't think it's quite possible yet. I think it just depends on the pharmacy as well, to be honest. But yeah, previously it was just based on like city and state government, so it is really great that federally, nationally, people can now buy it over the counter. So at least it's a step in the right direction. Unfortunately, $50 is a lot of money, so that still is a barrier, but it's a step in the right direction, so we'll be happy about that at least. So here's a Good Samaritan law. Okay, so Utah, so will I get in trouble for calling for help during an overdose? So no, because Utah has a Good Samaritan law. So essentially, this is going to protect anyone, like if you're gonna have immunity from arrest for drug possession, if there's drugs in the area, if there's paraphernalia, that kind of stuff, that will provide you immunity because you did call for help. And you're acting in the best interest of that person. That's essentially what this law is saying. The only thing that it will not protect is that if that person is breaking probation or parole, the Good Samaritan law will not protect that.
What if they have warrants?
That's a really good question. I'm not sure about warrants.
So it's a concern that I know is a lot of people are afraid to call for help for people that have warrants.
Do you happen to know, Heather?
So last I heard that, I can't remember what they call it, but like if you're in an environment and you're using with somebody and they're overdosing, you should be able to call 911 without being questioned. So, and I can't remember what they call it, but I think that's still on the back. Yeah.
So in other words, if you have a warrant and you call, you should have immunity.
Yeah.
That is the answer for the folks online.
And when did that law come in?
Oh, actually that's a good question. I don't know in this law. I don't know if it's in my notes or not. It's been a while, I think. But I don't actually know if I have it in my notes. No, I do not, so I don't know the answer. But I can look it up, I can find it out. Oh, thanks. Okay, so this is kind of the end of our the naloxone section, and we'll go into harm reduction next. So these are just some of the takeaways that I want you all to walk away with. So naloxone is not an opioid. It is an opioid antagonist, which is essentially meaning that it's blocking an opioid. It's effective. It works within a few minutes. And it's also super safe to give. Like I said, the only thing it's going to be doing is binding to those receptors in the brain. There's no way to overdose on it. There's no side effects. It's a very safe and effective medication. And that's what we want to tell the community, the world. So it is legal for you to have, it's legal for you to administer, and it's legal for you to give to others. But once again, I just want to reiterate this, that it only is going to work for about 30 to 90 minutes. So there is always a chance someone could re-overdose. So yes, you'll have 2 doses in each kit, but it's always best to have more than 1 kit if possible. And then last, yeah, it saves lives. So you're gonna walk away with some today. I have some resources at the end for some places that you can also get it for free. So we'll talk about it at the end. But yeah,
Amy?
yes.
So it's on October 19th, 1998, President Clinton signed the Good Samaritan Law.
So 1998 is the Good Samaritan Law. So it has been around for a long time.
And I don't think they cover warrants, because I actually know people who have got arrested.
I know, that was awesome.
All right, I hope that changes though, because I'd like to be able to tell people they can do it without doing it. I shouldn't even have a warrant.
Yeah, I'll definitely look into that a bit more and see if I can get a really firm answer on that. And so I guess before we move on to more just harm reduction stuff, last few things I'll get your question in 1 second. The last few things I want to talk about with naloxone is that just kind of some best practices is that one, the FDA did approve naloxone to be used a year after its expiration date. So if you do happen to have a kit that's expired, still use it. But best practice is to have one that, of course, isn't expired, because it will still work. It just might not work to its full effect, basically. Yes.
So is this good for all ages, even a person's young or elderly?
So all ages. I've had this question before about using it on a kid, but now I can't remember the answer. Alicia, were you in that presentation when someone asked about using it on a kid?
I was.
But now I can't remember the answer to it, actually. I know we looked it up, too. I think it is safe to use on a child, but I don't remember, so I don't want to give you a wrong answer.
So I know there's a kid around my work who just as recently as last week, he's 16 years old, he was administered 3 doses to bring him back. So I mean,
On a teenager, I would definitely use it. I'm talking more like a little kid, like a little child. I don't know, but teenager, yeah, teenager I think would be totally safe to give it to, yeah. But a little child, I'm not sure. Yes?
So what's the shelf life on it?
I think it typically is 2 to 3 years, but I'm not entirely sure. But what was your question? Sorry.
What about another those with chronic diseases like the type 1 people?
As far as I know, it's not going to affect any other diseases or chronic issues that people have going on, because as I said, all it's going to be doing is binding those opioid receptors in the brain. So there are no other side effects to it. So as far as I'm aware, if someone has other health conditions going on, it shouldn't have any effect on that.
about animals.
What was that?
About animals.
Says it is approved.
Oh, I
A
don't know.
lot of people who use drugs have animals.
I don't know. Yeah, that's an answer. That's a question for a vet. I know humans to a certain extent, not pets or animals. Did you say that you can administer to a child? Okay.
So it says it's covered by most insurance plans with no age limits
Okay.
or restrictions.
There we go. So I guess all ages. Yeah.
And that's because it's a low barrier medication.
Okay.
So.
All right. Great. And then so the last thing I want to talk about too is that we live in Utah, right? It's really hot, it's really cold. So technically Narcan and Naloxone are supposed to be kept at kind of room temperature. I believe the range is 58 to 82. You can read the fine print in the box. Something around those kind of more room temperature. So if you work in the community and you are out with your car or you are just out in the community and that's the best place you can keep it in your car. It's better to have it on you and have it experience temperature changes than to not have it at all. But it's kind of the same thing with the expiration date, where if you've had naloxone in your car for a year and you've experienced a lot of ups and downs in temperature, still use it. It's still going to work. It just might not work to its full potential because it has had those different temperature changes. But just maybe try to change it out every 6 months or so. But it's better to have an expired naloxone. It's better to have one that's experienced some temperature changes than to not have any at all. So those are kind of my takeaways for naloxone.
One thing you can do is keep it in some blankets. Keep the temperature steady.
Yeah, you can try to keep it in more of an
Keep it
insulated
your
thing.
trunk in the blankets, your emergency blankets.
And Narcan to dogs, to your animals, the answer is yes.
Is it? Okay.
It is yes. And that's on the health.gov website, so.
Oh, these.
The things we learn in these trainings, right?
Yeah. Yay. Okay.
For Google, right?
I know, right?
There we go. Learning with you as we
Super
go.
smart when I Google stuff.
All right. So harm reduction. So we can do something with these really high rates of overdose in our communities. And one is using harm reduction strategies. So there's not really a set definition of harm reduction, but essentially harm reduction is the overall purpose and goal of it is to keep someone alive in the hopes that they may seek treatment or recovery or whatever it is that they want out of their life, whatever their goal is. That is essentially what harm reduction, that's the ultimate goal, but there's a lot of different definitions. And so part of that is like where you see in the bottom here is meeting people where they're at, and you hear that a lot, but essentially what that means is that you're just trying to support that person, and we have a few more slides about that, but it's whatever the goal and wherever they're at in that current moment. So if they want a safer way to use, that's harm reduction. We can find safer ways to use. If it's just reduced use, maybe that's their goal, and that's going to be harm reduction. Harm reduction is essentially you're just trying to reduce the negative consequences associated with drug use. And then, so the other thing with like harm reduction too is that it's going to range. Like, it's a very complex issue, drug use, and so it can range from abstinence, it can like go to reduced use or to safer use. There's a lot of different aspects of harm reduction. And I do have these posters here that people are welcome to take. But I do want to point out these posters are really great. I mean, I suppose you can't really see it that much in the camera. But we use harm reduction in our everyday life. So you'll see these posters here where they have examples of life jackets, of sunscreen, of helmets. But then you also have your typical ones like, like a syringe exchange or a cigarette filter even is harm reduction. It's essentially what harm reduction is, you're just trying to reduce like negative consequences. So that's why you have your like condoms, you have naloxone, you have your child protection caps on pill bottles. All of these are harm reduction. And so we use these in our everyday life. So people are also welcome to take a poster. So these are some of the main principles of harm reduction, and I do have a handout that I'm going to pass around so you can take. So what we're going to read through right now is all of these on the front. This is just a free resource from the National Harm Reduction Coalition, so you can definitely go online and download this, and they have a lot of other resources. So I'm going to have you all take one of those. And so you can kind of like read along with me on these, but these are essentially the principles of harm reduction. So accepts. So that means that you're going to accept that for better or for worse, that illicit and illicit drug use is a part of our world, and you're going to choose to work to minimize its harmful effects rather than simply ignoring or condemning. Oh, thank you, Alicia. And then next, understands drug use. You're going to understand that it's a complex and multifaceted phenomenon that encompasses a continuum of behaviors, from severe abuse to total abstinence. And you're just going to acknowledge that some ways of using drugs are safer than others. It redefines successful intervention. And so that means that it establishes a quality of individual and community life and well-being. And it's not necessarily focused on stopping all drug use as a criteria for a successful intervention and policies, right? As Megan talked about in her keynote speech this morning, there's a lot of different pathways, and there's not one size or like one shoe fits all. Many people have different goals and different things that are going to work for them. And it comes from a place of non-judgment. So it just means that you're providing services and resources to people who use drugs and the communities in which they live in order to assist them in reducing harm. And then just a real voice for the user. So it just ensures that drug users and those with a history of drug use routinely have a real voice in the creation of programs and policies. And that are designed to serve them. So we want to give that voice. We want to have their input and understand from their perspective really what they want and what they need. And it gives back power. So it affirms drug users themselves as the primary agents of reducing harm in their drug use. And it also seeks to empower users to share the information and support each other in strategies to meet their conditions of use. And also recognizes hurdles. And operates from a place that just recognizes the reality of poverty, of class, of racism, of social isolation, past trauma, sex-based discrimination, and just other social inequalities that are going to affect people's vulnerability and capacity to just dealing with drug-related harm. And last, it doesn't sugarcoat reality. So it doesn't attempt to minimize or ignore the real and tragic harm that's associated with drug use. So we're not trying to pretend like there aren't harms. We're just trying to allow people to use in the healthiest and safest way possible. And maybe that is total abstinence. But it also could just be, like I said, just whatever that goal for that individual person. And really, that's where this whole meeting people where they're at, that's the idea, is that you are there to support them and their goals and their needs in that moment. Next one. If it'll work. Okay, so how does harm reduction work with peer support? So as a peer support specialist, really we want to focus on building that trusting relationship. And that is the beauty of being a peer support specialist. You're able to build that rapport with your clients, with your peers. But you really want to make sure that you're removing that bias and judgment on what your peers assigned to do. So you really want to make sure that your peers understand that you are supporting them. Just make sure that they know that you're on their side. You have their back. You're cheering them on. And you're not just trying to get them to stop use, but maybe it's just using in a safer way. And then you also want to understand, do they understand what harm reduction is? Do they understand how, different methods, different use? And you might just need to find different ways for them to decrease harm. And so that there's a typo in this. I did redo my slides, but the previous one I sent them. So you could also educate them on different ways to have a safer use, whether that's going to be a needle exchange for clean supplies. It could also be changing a method. So instead of shooting, maybe they're going to inhale. And there are safer ways to use drugs. Or maybe stability on medication-assisted treatment. Maybe that's going to be the best method for them. And so last, we really just want to also just ask, how can you help them? What do they need in that moment? And lastly, you just want to make sure that they understand that, your goal is to accept them as they are. And this is where it kind of goes to this last one of giving them stability, that you are there to support them in whatever it is that they want in that moment or need in that moment. So there's some of our kind of key skills to how we can use harm reduction in our peer support specialist workforce in our everyday role. I think I have maybe a couple more slides. I think we'll have plenty of time at the end for questions and playing around with things. So here's just some of our different resources. And so some of our local resources, so we do have Utah Harm Reduction Coalition. Utah Naloxone is a really great, they actually offer virtual Naloxone trainings, and they will mail you a kit. You'll actually get, this is where I got it from actually, they'll send you the syringe version of it, but they're virtual, and Dr. Jen Plum is really great. She's super knowledgeable, so I also suggest taking a Naloxone training from her. Utah AIDS Foundation, Southeast Utah Health, and so these are all places that you can get Naloxone from. The library actually also offers free Naloxone. You can go to the library and they also have it. You can just go up to them, and if you ask for Naloxone, they'll give it to you for free. This last bullet point is a certificate. So there is a training called the Harm Reduction Navigator Certificate, and it's in collaboration through Utah Syringe Exchange and the office or the Utah Department of Health and Human Services. I've taken that training, it's really great. It's usually only twice per year, I think in August and February. But it's another really great place if you want to learn more about harm reduction. And you do talk about like sex work and things like that in that training, so it is a really great place to also just learn more. Yes?
You're saying we could take that to the UHRC?
So this one, maybe I misspelled. I think it's called Utah Syringe Exchange, I think is actually, but yes. Yeah, so maybe they are the ones who host it.
They do the syringe exchange for sure.
Okay.
I just wondered if that's where the class is.
Yeah, so if you Google that Utah Harm Reduction Navigator Certificate, it will pop up. But I know it's in collaboration with the Department of Health and Human Services and another local nonprofit. But it is really great. I've taken it. It's a fantastic way to learn a lot more about harm reduction strategies. And like I said, beyond even drug use, they do talk about sex work and things like that. So there's a lot of other aspects of harm reduction that isn't just associated with drug use. So here I just wrote down some national, great, we're almost done. So just some national resources. So these are just some resources that you can look up for more education in harm reduction. They offer some different webinars, some different resources. So that's why I wrote those down, just because they might be some different resources that you don't typically go for or look up. Okay, so we're towards the end. So if you want to take out your phone and please take the post-training survey. This is essentially showing us how much you've learned.